Welcome back to the Deep Dive. We're here to really pull apart the key knowledge from essential texts so you get
Yeah.
insights you can actually use. Today, we're jumping into Chapter 5 of Basic Geriatric Nursing. It's all about mastering communication with older adults, a really critical area.
Absolutely. And this isn't just, about summarizing. Our goal here is to help develop real therapeutic communication skills. It's foundational. And we have to start by admitting, well, it's complex, right? We're trying to build rapport, exchange information, often across pretty significant generational differences.
Yeah, that generational context you mentioned is huge. When we talk about rapport, that mutual respect and understanding, we've got to remember the incredibly different experiences people bring. The book paints this picture, doesn't it? Today's oldest adults, they lived through the Great Depression, World War II, life without TVs or even private phones for many.
Right. And then you compare that with, say, the baby boomers. They grew up with Vietnam protests, massive shifts in social norms, technology exploding, these unique histories. They shape values, beliefs, perceptions in profound ways. That's exactly why the text hammers home. No generalizations. You approach every single person as an individual.
Okay, so that really sets the stage for maybe the most surprising piece up front, just how powerful the unspoken message is. Let's get right into Professor Marabian's 738-85 rule that the book highlights.
Yes. This rule is it's essential because it flips how you think about your interactions. Only a tiny 7% of meaning comes from the actual words, just 7. Then you've got 38% from paralanguage, that's your tone, pitch, how fast you talk. But the really massive part, 55%, comes from body cues, body language. So if you're just listening to the words, you're missing, well, more than half the conversation.
Wow, that's staggering. Especially when you think about being busy, maybe stressed. If I say, oh, sure, I have time for you, but my body's like angled toward the door, or I'm clicking away on a computer, the patient's going to believe that 55%, right? The body language.
Every time.
Every single time, exactly.
Yeah.
That nonverbal message just trumps the verbal one. Think about symbols, too, like uniforms, scrubs, name badges. They communicate status, identity. But for older adults, maybe with some vision changes, that name badge needs to be super clear. Big print, like the book suggests, maybe 12-point type, so they actually know who you are.
And what about just, how loud we talk? The source warns pretty strongly against shouting. Even if someone seems hearing impaired, why is yelling such a bad idea? Well, it's often perceived as anger or frustration. Even if you mean well, shouting can feel aggressive and it makes people defensive. It just doesn't work. For hearing loss, like presbycusis, that common age-related kind, it's far better to slow down a bit, speak clearly, maybe a little louder, but definitely in a lower tone of voice. And get close to their good ear if they have one. Those lower pitches travel better.
Okay, lower tone, not louder volume necessarily. Let's talk about space then. Proxemics, right? The study of personal space.
Yeah.
The chapter lays out these zones, but the safety aspect seems really key here.
Oh, absolutely key. So in, typical American culture, the sweet spot for talking, for care interaction, is personal space. That's about 18 inches to 4 feet away. It shows you're interested, you're engaged. But the big safety alert, the book flags. That involves intimate space, anything closer than 18 inches.
And you often have to be in that intimate zone for care tasks, right?
Yeah.
Helping someone dress, checking vitals. What's the specific danger if you move in too fast?
If you just barge into that space suddenly, especially with someone who might have sensory loss or maybe some cognitive impairment, it's startling. It can feel like a threat, honestly. And that can lead to a defensive reaction. They might lash out verbally or even physically. You absolutely have to announce yourself, make sure they know you're there, explain what you're doing, get permission before you get right up close.
Makes total sense. So, okay, if 55% is nonverbal, how do we make sure our verbal communication is also respectful and effective? The chapter gives clear dues. Identify yourself, use their preferred title, Mrs. Chin, Mr. Jones, listen with empathy.
And critically, we have to stamp out the don'ts. Especially that toxic habit the book calls elderspeak. This is such a clear point in the text. Elderspeak is basically a form of ageism.
Can you break down elderspeak again?
Yeah.
Because I think it's easy to slip into without even noticing.
Sure, it's things like using that sing-songy voice, making statements sound like questions, using pet names like honey, dearie, sweetie, and maybe the biggest one is using we incorrectly, like asking, are we ready for our bath now? It just diminishes the person, treats them like a child, it's fundamentally disrespectful, and chips away at their self-esteem.
Right. So foundational respect first. Then we get into the actual techniques for gathering information. Instead of just listing them all, maybe we focus on what the chapter suggests is most effective, like open-ended techniques.
Yes, exactly. Open-ended questions and statements are really the heart of empathetic communication. They create a space where the patient feels safe to share, to express feelings, concerns, without feeling boxed in. So that could be using reflective statements like, it sounds like you're feeling pretty frustrated with, or just paraphrasing what they said back to them to make sure you understood correctly. So what I hear you saying is that kind of thing.
I get the value there, but, you know, sometimes you're rushed. You need a quick answer. Why not just rely on direct questioning? The who, what, when, where, yes, no questions.
Well, direct questions definitely have their place for getting specific, urgent info, but the book warns, and this is important, overusing them is risky. If you just pepper someone with rapid-fire questions, especially an older adult who might need more time to process, they can get overwhelmed really fast. They might just clam up. You actually end up getting less information, not more. The less they participate, the less useful it is.
Okay, that makes sense. Avoid the interrogation approach. Now, the fourth technique sounds a bit intense. Confronting. Doesn't that sound aggressive? How is that therapeutic?
It does sound harsh, but it has a very specific, careful use. Confronting is only used when there's a clear mismatch between what the patient says and objective facts. Like maybe their description of how they take their meds doesn't line up with the pill count. You have to approach it objectively, non-judgmentally. Can you help me understand this? The count seems a bit different from what we discussed. But the safety alert here is absolutely crucial. You never, ever confront someone who's highly agitated or confused, especially someone with dementia. That will just escalate things, lead to conflict, it's counterproductive, and potentially unsafe.
Got it. Handle with extreme care or not at all if they're agitated. Okay, let's pivot to overcoming barriers. First up, sensory issues like hearing loss. We talked about using a lower tone. What else does the chapter suggest?
Right. Definitely minimize background noise, TV, hallway chatter, machines. Make sure their hearing aids are actually working, clean, battery's good. And use visual cues. Stand right in front of them at eye level. Many people try to lip read, even subconsciously, which, as the chapter notes, makes masks, which we're still dealing with, sometimes a real challenge because they block all those visual cues.
Yeah, the mask issue adds another layer. The text also really emphasizes pace and timing. Not just our pace, like not finishing their sentences for them, which is disrespectful, but also the timing of our response to them.
Yes, and this is where it gets into deeper ethical territory, I think. When we delay responding to call-lights or to requests, patients interpret that as us not caring, a profound lack of concern. And the book makes a really strong statement here. It says making older adults wait unnecessarily is actually a subtle form of abuse. We have to respond promptly, it reduces their anxiety, and it can actually prevent demanding behaviors later on.
Wow, that phrase, subtle form of abuse, really lands. Okay, moving to cognitive barriers. First, aphasia, that loss of ability to use or understand words, often after a stroke. Simple messages, picture boards help. But the book mentions something fascinating. Singing.
That's right. It's pretty amazing. Research suggests singing taps into a different part of the brain than speech, often one that's undamaged. So for some patients with aphasia, singing familiar songs can actually unlock surprising verbal fluency. It's used therapeutically to help regain speech. Really interesting.
Very cool. Now, for dementia, the chapter is clear. The communication responsibility falls heavily on the caregiver. What are the absolute must-do strategies here?
Okay, key things. Because they often can't focus on more than one idea, you talk about just one thing at a time. Ask only one simple question. Limit choices drastically. Would you like juice or water? Not, what would you like to drink? Keep the conversation focused on the here and now, not complex past events or future plans. And crucially, remember that behavior like agitation, pacing, repetitive sounds, that is communication. It usually signals an unmet need, pain, fear, something we need to try and figure out.
Behavior is communication. That's a vital lens. Okay, so we've covered physical and cognitive barriers. What about structural ones, like language differences? Facilities getting federal money have to provide interpreters, right?
Yes, it's a legal requirement, professional interpreters. And the text strongly warns against using family members or friends for important medical information. They aren't trained, they might be emotionally biased, they might filter or change the meaning without realizing it. It's just not reliable or appropriate for complex stuff.
So when you do use a professional interpreter, what are the rules?
Keep your questions short and clear. Use simple language, avoid jargon or slang, talk directly to the patient, not the interpreter, maintain eye contact with the patient, and, importantly, allow extra time. Good interpretation takes longer.
All right, final stretch. Team communication and patient teaching. Good care obviously depends on clear talk between nurses, doctors, everyone. If a nurse has to deliver bad news, what are the key guidelines mentioned?
It requires careful planning. First, Get your facts straight. Find a private, quiet place. Ask the patient who they want present with them. Make sure you have enough time. Don't rush it. And maybe, most importantly, be prepared to respond immediately to their emotional reaction, whatever it is, sadness, anger, shock, denial, and have a plan for follow-up support.
Seems essential. And for routine communication, like nurse-to-provider updates, handoffs, phone orders, the gold standard tool is ISBAR-R, isn't it?
Absolutely. It's pretty standard now, adapted from military models. Because it works. It reduces errors by making communication structured and focused. It stands for introduction, who you are, who you're calling about, situation, what's happening right now, background, relevant context, assessment, what you think is going on, recommendation, what you need, and readback, confirming any orders. And the book stresses you got to have your ducks in a row before you call, have the chart, have your assessment data ready. That's another key safety point.
Preparation is key. Okay, last piece, patient teaching. How do we make sure older adults actually learn what we need them to know?
Well, adult learning principles apply strongly here. They learn best when the information feels relevant to their life right now and when it helps them solve a problem they're facing. Technique-wise, break things down. Small, manageable chunks of information. Go from simple ideas to more complex ones, and whenever possible, use hands-on practice. Show, then have them do.
And what about printed handouts? Any specific tips there?
Yeah, the chapter gives specifics because vision changes are so common. Use at least 12-point type, maybe even larger. Use simple, clear fonts, nothing too fancy. Good contrast, black on white is usually best. And leave plenty of white space. Don't cram the page. Oh, and timing matters for teaching too. Don't try to teach when they're in pain, super tired, anxious, or distracted, like definitely not during their favorite TV show. Find a quiet, comfortable time.
That was a really thorough walkthrough.
Yeah.
Fantastic stuff. For me, the big takeaways are definitely that 738-55 rule, realizing nonverbals are king.
Yeah.
And the huge difference between just hearing words and truly listening with empathy. And gosh, the absolute need to ditch elderspeak permanently.
I think that sums it up well. When you apply these skills, it really does shift the whole relationship. It becomes less about just doing tasks and more about connecting with the person, upholding their dignity.
Which ties right back to that really powerful thought you highlighted earlier from the chapter. The idea that making older adults wait without need is a subtle form of abuse. That makes you think, doesn't it? How mastering clear, efficient communication tools like ISBAR-R for team updates isn't just about checking boxes. It directly impacts patient dignity. It respects their time, reduces their anxiety. Your communication skill is part of their quality of care.
Couldn't agree more. A really practical application of dignity in action.
Well, thank you for being part of our little last-minute lecture family today. We really appreciate you diving deep with us on this one.